Muy buenos días, tengan todos y todas ustedes. Vamos a dar inicio, esperando se encuentren muy bien, por lo que les solicitamos cerrar sus micrófonos y sus videos, a excepción de los ponentes y moderadores, para obtener una mejor recepción y tener una transmisión genial para ustedes, sin interrupciones. Asimismo, quiero mencionarles que para realizar las preguntas, utilicen el chat que tienen a su derecha, para al finalizar tener una sesión y poder contestarles. También vamos a contar con un link para que nos apoyen contestando una encuesta de satisfacción. Es muy importante para nosotros para seguir superándonos con estos seminarios internacionales. En nombre de la Escuela de Medicina y Ciencias de la Salud, TechSalud, les damos a ustedes la más cordial bienvenida a este seminario internacional virtual del Grupo de Investigación y Terapias Innovadoras en Oftalmología y Ciencias Visuales. El día de hoy contamos con el tema de Topical Immunotherapy for Ocular Surface Diseases. Me voy a permitir presentar a la coordinadora de este seminario. Ella es la doctora Denise Loya García, es cirujano oftalmólogo con alta especialidad en córnea, cirugía refractiva y enfermedades externas. Cuenta con un doctorado en Ciencias Clínicas, es integrante del Instituto de Oftalmología y Ciencias Visuales del Hospital Zambrano León, TechSalud. Es investigadora asociada del GIE de Terapias Innovadoras en Oftalmología y Ciencias Visuales. Así como también la doctora Denise Loya es coordinadora de Comunicación Científica de MAR. Es el Colegio Nacional de Investigación en Ciencias Visuales. Enseguida le cedo la palabra a la doctora Denise Loya para que nos hable un poco del objetivo de este seminario y nos presente a nuestro invitado especial. Doctora Denise, por favor, adelante.
Hola, muy buenos días. Gracias, Maggie. Bueno, muy buenos días a todos. Gracias por acompañarnos el día de hoy. Y pues es para mí un enorme placer y honor tener con nosotros al doctor Sandeep Jain. Si me puedes poner la, Maggie, por favor. Compartir. Gracias. Lo voy a hacer la plática en inglés. Pueden hacer las preguntas en el chat, ya sea en inglés o en español, como ustedes gusten. Y voy a leer la semblanza del doctor Sandeep Jain en inglés. Y bueno, welcome Dr. Jain. Dr. Jain is a surgeon ophthalmologist, and he's the director of the Cornea and Translational Biology Laboratory in the University of Illinois at Chicago at the Department of Ophthalmology. His research work is funded at the National Eye Institute, NIH, and he has led to numerous publications in professional journals, as well as development of drugs for treating ocular Gvhd that are in phase 1 and 2 clinical trials. He has received numerous awards and recognitions, and he actually is a clinician scientist and a professor of ophthalmology at the USC Department of Ophthalmology and the director of the UIC Dry Eye Clinic and Ocular Graft versus Host Disease. It's such an honor to have you here, Dr. Jain. Please, you can share with us your work.
Thank you very much, Denise. It's always a pleasure to see you and talk to you, and for Dr. Garcia for inviting me to give this webinar. It's indeed an honor, and I look forward to this of presenting my work, and then after that we can have some questions, and I will try my best to answer them. Without further delay, I may start with the presentation, if that's okay with you, Denise?
Yes, please. Go ahead.
So what we are going to do is share the screen now, and hopefully it will just work fine. And I think you can see the first slide and the laser marker, right? You are all able to see that?
Yes, we see it.
Perfect.
I think you need to stop sharing because something is wrong with the presentation, I guess. Try to do it again, please.
Okay.
Better, yeah.
Perfect.
Okay. Perfect. So now that we are, it looks good on the screen, we'll start. So what I'm going to do today in the next 40 minutes or so is to take you on on the journey of how we figured out new therapeutics for dry eye and ocular surface disease. And we are very excited about these developments because there is a great potential that we may be able to introduce the first biologic immunotherapy for dry eye and ocular surface diseases. So like Denise said, I'm a professor of ophthalmology at UIC College of Medicine in the Department of Ophthalmology. And we see a large number of patients with severe ocular surface disease, many having dry eye disease, which you probably see them also, graft versus host disease, Sjogren's disease patients, and they are suffering. It's not that in these patients, dry eye is a nuisance, meaning that they have some irritation and they use artificial tears and they'll be okay. These patients are really suffering. Their quality of life is reduced because they are not able to function well and they are not able to work. And some of them are on disability because of that. So it's a major problem. We're not talking about some just little irritation in the eye. We're talking about ocular surface disease that impacts the quality of life. And it's a big problem. And we don't have too many treatments for this. As you very well know, there are only treatments that are available, at least in the US, that have been approved by the FDA. There are only two, basically. The trade names go by Restasis, Cequa, and Xiidra, and they have in common that they act against the T cells. So we say that that's very important to know and understand, that although we have these three medications, two of them are exactly the same compound, and they work through a common mechanism of T cells to reduce inflammation on the surface of the eye. And there is a big gap out there on how to treat the surface diseases better. So I'm going to spend a little time on this slide, and perhaps the most amount of time on this slide. It looks a very busy slide, but bear with me, we'll walk through it. Because I think if you understand what I'm going to be telling you on this slide, you will have a good concept of how to think about dry eye disease and ocular surface diseases in general. The most common paradigm right now, and that's why we have these three medications. The most common reason we feel dry eye happens, it is because there is an environmental stress on the surface of the eye. That environmental stress causes antigen presenting cells in the cornea and on the surface of the eye to get activated and then move to regional lymph nodes. In the regional lymph nodes, these activated antigen presenting cells, they stimulate T cells. The T cells, there is T cell hyperplasia, so the numbers increase, and then they home in back to the surface of the eye. So this mechanism that is shown over here is the accepted current paradigm of why dry eye happens. And that is why, because these T cells are homing back to the surface of the eye and causing ocular surface inflammation, we have strategies to inhibit this T cell hyperplasia by using cyclosporin. So that's one thing. The second thing is that how do cells come on the surface of the eye? Well, this is the main mechanism, but in certain diseases like autoimmune diseases, graft versus host disease, they're autoreactive T cells and B cells. They don't need to be activated. They just are there in systemic circulation. They are in the body and they just home in directly to the surface of the eye. So now if you think, hey, can I give Restasis over here and block this? Answer is no, because the cyclosporin does nothing to prevent migration of T cells. So this mechanism will not be stopped by that. But yes, Xiidra can help because that acts against T cell adhesion with these surface receptors which are on the surface of the eye. So these two mechanisms are there. Then there is another mechanism why there is pain. There is a trigeminal cornea axis. When the cornea is inflamed, it causes the trigeminal nerve inflammation, which causes pain, and that causes certain cytokines to increase in the cornea, like interleukin-8, which brings neutrophils to the surface of the eye. So look at the number of cells that are coming to the surface of the eye. There are T cells coming from here. There are autoreactive T cells, B cells coming on the surface over here. And from cornea trigeminal axis, there is neutrophils coming on the surface of the eye. The neutrophils also come on the surface of the eye because of the dead and dying cells, which are a big stimulus for neutrophils to come in. And so one of the strongest stimulus, in fact. And why are there dead and dying cells on the surface of the eye? Well, you know that the corneal epithelium is in a constant state of rejuvenation. It's constantly being produced. The surface cells are being shed. They are shed in the tear fluid. And so once you have these cells in the tear fluid, they attract neutrophils towards the surface of the eye. And that's another reason why you have neutrophils on the surface of the eye. So now, what I have told you so far is that there are these various mechanisms which brings all these cells to the surface of the eye, the T cells, B cells, and neutrophils. Now, what do they do? Okay, we know that T cells can cause inflammation. That's a T cell mechanism of inflammation. What people don't know in as greater detail is what are these neutrophils doing? And so let's talk about these neutrophils for a moment. These neutrophils come to the surface of the eye through IL-8 or through these dead or dying cells. They come to the surface of the eye. They become activated over there. How do we know they get activated? Because they express surface receptors. And then they do something that is very interesting. The DNA of the neutrophils, it comes out as a spider web on the surface of the eye. And this spider web, which is made of DNA, has many very potent bioactive molecules sticking on the surface, like interleukin-8, myeloperoxidase, neutrophil elastase, oncostatin. And all of these molecules, they are fine. They're good defense mechanism. Why? And if under normal physiological conditions, that's a good thing to have these molecules and to have this DNA on the surface, because it will prevent bacterial infections and will protect the surface of the eye, and that's why it is important. But when it becomes in abundance, meaning it starts collecting more, then it becomes a problem. So that's when it becomes a problem, when it becomes in abundance. So that's one reason why you can have surface disease. There is another problem that happens when these nets increase in amount. There is an enzyme that comes up, which is called PAD4 enzyme. There is an enzyme that comes, which is called PAD4 enzyme, which citrulinates the proteins on the surface of the eye. And this is an important concept, and I'll spend a little bit of time over here. What does citrullination mean? Citrullination means that just one amino acid, arginine, is changed to citrulline, and when that happens, the body stops recognizing the protein as self-protein. So if there is a protein on the surface, which is, let's say, histone, it becomes from histone to citrullinated histone. Then the body says, hey, I don't know you. Who are you? So the tolerance is broken, and the immune system thinks that this may be some sort of a virus or bacteria, and it sends its armies, which is the T cells and B cells, and launches an immune attack against this protein. So when citrullination happens, the self-tolerance breaks down and an immune response comes up. And that's what we are showing over here in this diagram, that the T cells and the B cells, they recognize the citrullinated proteins and form these autoantibodies, which cause a lot of problems. They cause dendritic cells and other cells to produce cytokines and so on. They cause neutrophils to get activated. They activate the complement system. and all of this produces disease. So this was a slide on which I spent some time, but it's important to know that important to know what's happening on the surface. So this is what I was telling about neutrophils, how neutrophils form nets. Its DNA comes out and it is decorated with many bioactive molecules. And this is experimentally, we can see the DNA coming out of neutrophils. And there are many net-associated proteins, histones, neutrophil elastase, cathelicidin, MPO. They're all on the surface. And once they get citrullinated, the self-tolerance breaks down and the immune attack against these molecules comes up. And we know that these nets are pathogenic because in our lab, we generated these nets and then put them on a mouse cornea. And we saw that when we place the nets on the mouse cornea, they cause surface disease. Now this is another concept that I want you to understand a little bit. What we also tried to do was to see what are these autoantibodies and nets. Nets are the starting point. Neutrophil and nets are the starting point, meaning that that's when the proteins are being released on the surface of the eye. And they can cause disease on their own. So that's one way in which disease can happen, is if there are increased number of nets and net-associated proteins on the surface of the eye. So that's one. Second way the disease can happen is once the proteins become citrullinated, they cause an immune response, and autoantibodies, which are called anti-citrullinated protein autoantibodies or ACPAs, they come on the surface of the eye. So that's the second way. So the first way is nets and net-associated proteins. And the second way is the autoimmune response that happens. So nets we are showing over here, autoimmune response we are showing over here. That's why we've separated them into two boxes. And we see that certain diseases like Sjogren syndrome, they have a lot of antibodies, but not too much of nets on the surface. And certain other diseases like graft versus host disease, they have lots of nets and net-associated protein, but not too much of anti-citrullinated protein antibodies on the surface. So diseases, these dry eye diseases and many ocular surface diseases, if you try to figure out what is the ratio of nets and ACPAs, they occupy different space on the spectrum. And the spectrum that we are saying ranges from autoinflammation to autoimmunity. Autoinflammation is a relatively new concept that we are trying to move towards, which is a way of saying that the disease is produced over here because of the innate immune system, meaning neutrophils and neutrophil-associated proteins and so on. So that's autoinflammation. And what we are saying in autoimmunity is that the disease is being produced by autoantibodies and the adaptive immune system, something like what happens in Sjogren's. So here is autoimmunity, here is autoinflammation, and this is a spectrum extending from autoinflammation to autoimmunity. And what we are saying is that the dry eye disease pathogenic spectrum spans from autoinflammation to autoimmunity, depending on what is happening on the surface, whether it's nets and net-associated proteins, or it is autoantibodies which is causing the disease. So I think that's a new concept that we are proposing based upon our understanding so far. Now let me quickly take you through some of the data that we have and some patient data that we have. Now these things that you see floating around on the surface of the eye in patients with severe dry ocular surface disease, this is a patient with graft versus host disease. This is a patient with Sjogren syndrome. We see in the tear fluid this mucousy kind of things, mucocellular aggregates is what we call them, these things floating around, and we don't pay much attention to them. We say, well, this is probably mucus. It's not. What it is a collection of cells, neutrophils, and neutrophil extracellular traps. This is a sign of active inflammation. It is composed of cellular and molecular components of inflammatory pathways, which is neutrophils, T cells, B cells, epithelial cells, and all the proteins that we talked about, histones, myeloperoxidase, and so on. They are a lot inside here. So what we did was we collected this, we looked at it under the microscope, we found all these cells, and then we stained it with specific antibodies for neutrophil elastase, citrullinated histone 3 antibody, and we found colocalization of these. Basically, this is the definition of NETs. When CYT-H3, citrullinated H3, and neutrophil elastase, they co-localize, that means that you are looking at NETs. So that was in the tear fluid. Have you seen these findings on the cornea? Most of you have, that there are these mucus-like strings that are attached to the cornea when the tear production is 0 or very, very low. We find this all the time. And the question is, what is this? What is this whitish material that sticks to the cornea? Well, we took a filter paper and placed on the cornea, lifted it off, and we stained it again with the same combination of antibodies, neutrophil elastase, CYT-H3, and we found that these are also NETs. These are basically, again, inflammatory material that is adherent to the cornea. So that shows us that there are these NETs present in the tear fluid, and they are adherent to the surface of the cornea. These are filaments, and filaments, you know, we see them all the time in severe dry eye disease, but what are they? We lifted them up carefully, and we put them, processed them for microscopy, and then stained them with specific antibodies. And we found that they're actually enveloped with a lot of neutrophil extracellular traps, which we see here in red. These are material that has come out of neutrophils. Of course, they are made up of a lot of epithelial cells and a lot of DNA inside, extracellular DNA. So the filament is composed of an envelope of neutrophils and neutrophil traps, along with a lot of epithelial cells, along with a lot of extracellular DNA inside these filaments. Tells you that this process extends to more than mucus. Then what we did was to perform impression cytology to see which cells are producing citrulline. And we figured out that it is basically neutrophils, neutrophilic proteins, which are citrullinated on the surface of the eye, although there could be some epithelial cells also. So we did tear fluid citrulline levels and PAD4 enzyme, which makes the change from arginine to citrulline, and we found that they were much higher in dry eye patients than in non-dry eye patients. Then we looked at immunoglobulins in the tear fluid, and we found that compared to healthy subjects, Sjogren syndrome and definite Gvhd patients had more immunoglobulins. So that kind of feeds into what I was saying, that that because of all the changes on the surface, the NETs formations, the citrullination, and the cells forming autoantibodies, the immunoglobulin content on the surface of the eye is higher. And the kind of immunoglobulins that are most prominent are IgGs in disease. We know in healthy subjects, IgA and IgG are roughly similar in amount, but in disease, it's IgG which is most abundant. And we found that the kind of autoantibody that was most important for us is anti-citrullinated protein antibody, ACPA. ACPA is against citrullinated protein. So this is an antibody. Again, the name is anti-citrullinated protein antibodies, which is against citrullinated proteins. And these antibodies are considered to be pathogenic, not just by us on the surface of the eye, but in rheumatoid arthritis, for example. In the synovial joint, they're supposed to be causing inflammation. We know that in rheumatoid arthritis, they're a big problem. And I think they're a big problem there, they're a big problem here. These are ways to show that ACPAs, anti-citrullinated protein antibodies, are not just one antibody, but there are many different. This is a family of antibodies. There is citrullinated fibrinogen. These are all the ones we picked on the surface of the eye. Citrullinated fibrinogen antibody, enolase, pimentin, histone 3 protein, histone 4 protein. So there is a lot of so many different proteins get citrullinated, and there are antibodies coming against it. So there is polyclonality. That also means that if you target only one antibody, it's not going to work because there are so many out there. So ACPAs needs a generalized strategy to if we are to reduce their effect. This slide shows that ACPAs, which is what we are focusing on, is not the only autoantibody on the surface of the eye. SSA, which we know in Sjogren's, that's present on the surface of the eye as well. Beta-2 glycoprotein, SCL70, they're all present on the surface of the eye. So what I'm telling you is that it's not just the T cells, which we know the current paradigm, which is causing problem on the surface of the eye, inflammation. These autoantibodies are also contributing, and that's something we do not talk about or think about as much. And that's the most important point of this presentation, which is that the immune system, the adaptive immune system, is equally important as T cells in pathogenesis of dry eye and ocular surface diseases. Now, this slide shows that we used some of these ACPAs, anti-citrullinated protein antibodies, put them on a mouse cornea and see how from B1 to B2, when we apply on the mouse cornea, how much surface disease develops. And we figured out also that if we added immunoglobulins with it, then the disease does not happen. So that gave us an idea, and we said, hey, so if we were to try and reduce the problems that ACPAs can cause on the surface of the eye, then how do we do that? And we said, well, one of the very, very potent therapies out there is pooled human immune globulins, which you may have heard. People give them as intravenous immunoglobulins or subcutaneous immunoglobulins and so on. And they are very expensive therapy, but they are given intravenously. Large doses of immunoglobulins are injected, and they have phenomenal anti-inflammatory effects. Why do they have anti-inflammatory effects? Because when from an individual patient, if you draw blood, it's not going to work. We need tens of thousands of patients. We need to pool their plasma and then remove their immunoglobulins. When we do that, those immunoglobulins are anti-idiotypic antibodies, which means antibodies to antibodies. So these pathogenic antibodies I was talking about, there are protective antibodies against these pathogenic antibodies in that pooled human immune globulin. That's why it works. So it is given off-label for many autoimmune diseases. In ophthalmology world, it is given for ocular cicatricial pemphigoid. In that condition, IVIG has been given intravenously. It causes neutrophil function it inhibits netosis, it inhibits antibodies, it inhibits immune complexes, it inhibits dendritic cells. It causes expansion of T regulatory cells. So this pooled human immune globulins has many actions against the immune system when it is dysregulated. So that's very important point. Now we said, well, because it is called IVIG if you give intravenous, and because it is called SCIG if you give it subcutaneous, so why don't we just call it ocular surface immune globulin, or OSIG, OSIG, and that kind of makes sense. So we started calling it OSIG for our purposes, that this is OSIG. It has many effects. It inhibits neutrophil activation, inhibits formation of nets. It has inhibiting autoantibodies inside, anti-idiotypic antibodies, natural antibodies. It inhibits complement system activation. It inhibits autoantibodies to interact with Fc gamma receptors on dendritic cells and so on. So it has so many actions that it would make sense to use it in humans on the surface of the eye. And in vitro experiments showed that it works. And so we said, okay, let's use it. So we went to FDA, we got a investigational drug assignment, a IND assignment. And under that IND, we performed a clinical trial, a pilot clinical trial, where we gave OSIG eye drops, which have pooled human immune globulins, 4 milligrams per ml. Why 4 milligrams per ml? Because that's 50% concentration of immunoglobulins, physiological concentration of immunoglobulins in the body. And we gave them twice a day for 8 weeks in severe dry eye patients. And we saw that the symptoms reduced significantly when we gave OSIG eye drops twice a day. And the corneal staining also reduced significantly in the OSIG group. Not just that, we looked at biomarkers, and interleukin-8 reduced significantly in OSIG group. Other neutrophilic biomarkers reduced significantly, extracellular DNA reduced significantly, and the percentage of eyes that showed clinically important improvement in OSDI, corneal staining, and other clinical parameters were also significantly greater in the OSIG, in the patients who received pooled human immune globulins, which we are calling OSIG eye drops. So that was very interesting and very encouraging. These are some of the pictures from that clinical trial. And you can see over here that there is this lissamine green staining of the cornea, which is quite extensive before OSIG treatment. And after OSIG treatment, it is much better. On the, in the control group, which did not receive OSIG eye drops, actually it became worse. The control was normal saline. And then there are many other patients which showed similar, but I'll focus on this patient with graft versus host disease who had SLK type of findings on conjunctiva, superior bulbar conjunctiva stained intensely with lissamine green. And after OSIG eye drops twice a day for 8 weeks, became much less. And this sort of reduction we did not see when in patients in whom we did not give OSIG eye drops. So vehicle patients did not show that. We did off-label also, we are treating a lot of patients with OSIG eye drops, mostly ocular Gvhd, Sjogren's syndrome patients, ocular cicatricial pemphigoid, Stevens-Johnson syndrome patients. And when we treat them off-label, we are seeing that a lot of them are improving, say that they are improved or much improved. More than about 75% of them. Of course, this is off-label, so we cannot do very good assessments. But again, it shows us that, that these drops work. Now, I'll give you a few examples. This is a patient with Sjogren syndrome. Lissamine green staining shows cornea filled with SPKs. Very, very bad disease here. And we gave IV OSIG eye drops for 2 months, 3 times a day over here. Cornea cleared up quite a bit. Because these are relatively expensive, she stopped the treatment, and then the cornea again became messed up. So that told us that OSIG eye drops work. This is a patient with pemphigus vulgaris with a lot of conjunctival inflammation. See how red the cornea, conjunctiva is over here? This is before we started using OSIG eye drops. And this is a month after OSIG eye drops, 3 times a day in this patient, and you can see the difference. The redness was much, much significantly reduced. This is a patient with Sjogren syndrome with inflamed eyes, a lot of SPKs, conjunctival injection quite a bit, and after 4 weeks of treatment, looked much better. This is another patient with non-healing epithelial defect, and was a steroid responder, so we couldn't use steroids as much. And this is something that I have to stress. Right now, we are using OSIG eye drops in patients who have recalcitrant disease or who are steroid responders, and we run out of ideas on what to do. And in this patient, this was the epithelial defect. We wasn't healing. We tried bandage contact lenses. We tried a lot of things. And then we, in addition to those treatments, we gave OSIG eye drops 3 times a day, and the defect healed. And the eye became much less inflamed also. This is a patient with graft versus host disease. A lot of keratinization, was very, very painful for her. And then we started her on OSIG eye drops. The most impressive thing about this patient was that her pain reduced significantly after starting OSIG eye drops, but also the keratinization was much less. So I'm gonna tell you how we do these things and what our plans are. This is the overall way in which we function. We have our dry eye and ocular Gvhd clinic, which is a referral clinic. When we get a lot of inputs from many different sources, patients come in and we do a structured exam. Everybody gets the same exam, regardless of whether they're a study patient or a clinic patient. And they all sign the consent form, and we go through a detailed structured examination. And then we do a lot of things, but there are many questions still that are there that need to be answered. One of the questions is whether these antibodies that I talked about, they can directly cause ocular surface disease, or they have to cause ocular surface inflammation, and then secondarily ocular surface disease happens. So these are the mediation analysis that we are currently engaged in. And hopefully we'll get answers to some of the questions that are there regarding these autoantibodies. Our translational research model is pretty extensive. We have a dry eye ocular Gvhd clinic, which is connected to the clinical trial center, and our translational biology laboratory. We have a philanthropy arm, because all the things that we do, it's not fair to just say that if you can afford it, you can get it, but if you can't afford it, you can't get it. So bottom line is that if somebody comes to the clinic, they need the treatments. If they can't afford it, we are able to give them. And then there are startup companies that have been spun off from all this effort, and they interact with this system also. So I wanted to reserve a lot of time for question answers. What I'm telling over here is a change, and I'll spend another 2 minutes to summarize. What I've just told you is a paradigm shift in our thinking about dry eye disease. What the current paradigm is that dry eye disease is a T cell mediated inflammation. And that is true. We are not saying that is not true. That is true. And that's why you have Restasis, and that's why you have Sjogren, that's why we treat with what we are treating with. What we are saying with all this data is that there is another factor that contributes to surface inflammation that needs treatment as well. And those are the autoantibodies on the surface. So the shift in paradigm that we are making is that autoantibodies also contribute to the dry eye disease pathophysiology in addition to the T cells. Now, these autoantibodies, they can cause disease. They can cause disease not just on the surface of the eye, they're causing disease in other systemic situations also, like rheumatoid arthritis, for example. And how do we take care of these diseases? We have figured out one way, which is sort of a broad spectrum immune therapy, if you will, like steroids for inflammation. Pooled human immune globulins is a broad spectrum immunotherapy. Why does it work? Because it has in it a lot of anti-idiotypic antibodies, a lot of natural antibodies, and these antibodies have many actions against plasma cells, T cells, complement system, neutrophils, which prevent disease due to these autoantibodies. And we have good initial data. We are moving forward towards creating more data. We will love to have collaborations with your systems to try and see whether whether pooled human immune globulins work for you in your settings, in clinical trial settings over there, or clinical study settings. That would be something that would be a very those collaborations would be very interesting for me. So I will stop over here and take any questions that you may have at this point.
Thank you very much, Dr. Jain. It was a wonderful and very illustrative talk. I think every time I hear from you, I learn a lot, and my mind keeps just spinning because there's a lot of information and it's very, very interesting. I think you have a wonderful work there and obviously a wonderful team. And thank you very much. It was very, very wonderful talk. And there are some questions from the audience. I will try to address them, okay? So one of them is, what are the theoretical triggers for this autoantibodies to appear?
What are the triggers?
Yeah.
So the biggest trigger for these autoantibodies to appear is inflammatory cells, or neutrophils, for example. Like I said, when they transit on the surface of the eye, they release their intracellular material on the surface of the eye, along with enzymes that can mutate the proteins, that can change the proteins. That's the problem. And why do these neutrophils come on the surface of the eye in the first place? They are coming on the surface of the eye because they are being attracted from the circulation. And that attraction is provided by dead and dying cells on the inside the tear film. In dry eye disease, there are more of these dead and dying cells in the tear film because the turnover of the epithelium on the surface of the eye is increased in surface diseases, in dry eye disease per se. So, so that's the problem. That's the trigger, which is that that the surface of the eye is shedding more cells. It is there are more inflammatory cells that are being attracted from the circulation, and they are coming on the surface, and then they're releasing all these bioactive molecules on the surface, and the enzymes which transform these proteins. And once that happens, the immune system becomes charged and sends these autoantibodies and start producing disease.
Okay, thank you. There's another question here, and it says, what is the role of tacrolimus eye drops in Sjogren's versus ocular Gvhd?
So tacrolimus is a good anti-inflammatory immunosuppressive agent, and it is used off-label, and we use it off-label in many situations, especially in patients who have a steroid response and we cannot give steroid. So it's a good steroid sparing agent in my view, like cyclosporin. So at some situations, we compound cyclosporin or tacrolimus eye drops and try to reduce inflammation on the surface of the eye in graft versus host disease and Sjogren syndrome. I think it's a good strategy. I think it works. It's just that some patients are not able to tolerate it as much because their surface is just so inflamed that any compounded medication, even if it's preservative free, it causes stinging and burning. So, but yes, it's a good strategy. I support it.
Okay, thank you very much. There's also another question. Based on your clinical experience, is there a way to differentiate the ethiopathology of dry eye disease between the two mechanisms that you mentioned before?
Yes, and I think we need to do that. That is a very important question. I think the reason why this is an important question is that if we are able to do so, we can tailor our therapies accordingly. And how do we do this? This has to be a clinical as well as a biochemical differentiation. Clinical differentiation, there are some clinical signs which are more common, for example, in ocular Gvhd than in Sjogren's. One of the clinical signs that is more common in ocular Gvhd and is not seen in Sjogren's is conjunctival subepithelial scarring under the upper lid and also in the lower conjunctiva. So if you flip the lid and you see a linear conjunctival subepithelial fibrosis along with SLK type of staining, you know it's more of GvHD kind of picture than Sjogren's kind of picture. But from our perspective, if you sample the tear fluid, and if we know in the tear fluid how much extracellular DNA is, which is indicative of NETs, how much IL-8 and neutrophilic biomarkers are there, how much ACPAR or antibodies are there, then you can make a differentiation better. But those point of care tests have to be developed to come into regular clinical practice. We can do that as a research in the research environment. Difficult for people to do it in clinical settings. But I think these tests will come up, these point of care tests will develop. I think we are moving in that direction, absolutely moving in that direction. And in the years to come, I foresee these tests commonplace in clinical practices to differentiate etiologically and then tailor the treatments.
Okay, thank you. As you present before, regarding the therapy in your clinical trials, you said that after a month, the patient stopped the treatment and the disease got worse. So how long do you think the patient will need to keep with this therapy?
I think the disease, the reason why these diseases are chronic is because the process doesn't stop. We talk about the eye, but the eye is connected to the body. So if there is a systemic immune condition like rheumatoid arthritis or systemic lupus or something like that, then can you hear me still?
Perfectly.
Okay, yeah, because the screen changed for some reason. So, that does not change. So the eye is under constant attack from the systemic disease. So we have to constantly use it. The second thing is that even if there is no systemic disease, there are self-replicating, self-propagating vicious cycles of inflammation that are set up on the surface of the eye. And we need to break these cycles. And this therapy does a good job probably breaking these self-perpetuating inflammatory cycles that develop on the surface of the eye. And if you stop the therapy, they just re-emerge. So I think when one has to use this, unfortunately, for a long time, and if you stop it, I think there is a risk of the condition just coming back again.
Okay, thank you. There's another interesting question, and it says, does the etiology, example, autoimmune disease versus primary Sjogren, change the antibody type?
Yes, the antibody types are different in different conditions, but we obviously do, at this point in time, we don't have an exact idea about what specific antibodies are there in which specific condition and how much. But this much is certain that the antibody profile is different in different conditions, yes. One thing that also I would like to stress over here is that the surface of the eye possesses a complete immune system. It does not need the rest of the body to produce antibodies. So if inflammation develops on the surface of the eye, it can produce autoantibodies just by itself. It doesn't need systemic participation. That's very important to know. And also that is important because it could be, things could be the other way around, that the surface of the eye gets the inflammation, gets citrullination, forms the antibodies, and that is what sensitizes the rest of the body to then develop other systemic immune diseases like rheumatoid arthritis. So the eye surface could be the initiator of rheumatoid arthritis, which we don't think about. We think about the other way around, that rheumatoid arthritis is causing eye disease, but it could be that the eye disease was the one that contributed to rheumatoid arthritis because the surface of the eye has a complete immune system.
Yeah, I think that is a very interesting point. When we deal with these patients with a rheumatology specialist, and sometimes they don't get that the eye, it's with inflammation despite the systemic inflammation. I think this is a very interesting point, and it is very good to hear it from you, because I think more investigation and research needs to be done regarding this topic. There's also another question. It says a big problem in administrating eye drops is that they are cleared very fast from the tear film. I just wanted to ask if there is a transporter in the eye drops you developed to increase the exposure time of the IG pool to their ligands.
Yeah, I think it is the runoff times are a problem, yes. And so currently, because of the way we are set up, we are diluting it in normal saline, and that's fine. But when we move forwards to clinical supply formulations, then we'll have to increase the viscosity a little bit so that it stays on the eye longer. I think it makes sense that we use inactive ingredients inside eye drops that increase their viscosity and retention time to a little bit longer. But for this particular eye drop, for pooled human immune globulins, the nice thing is that its half-life is very long, 21 days. So once we put on the surface and it attaches to the receptors, it's going to stay there. And then we are using it for 2 or 3 times a day. So we are giving enough bolus on the surface of the eye for the active ingredient to stay over there just fine. So it doesn't enter the eye. So the immune globulins have no way it can enter the eye. It's just stay on the surface. But they stay on the surface for a pretty long duration of time once they attach to the surface receptors. The nice thing about eye drops is that we can ask the patient to use them more often. So even if they run off, so the way we ask them to use the eye drop is to lay down on the bed and then use the eye drops and don't get up and for about 2 minutes or so that it acts. We don't tell them to use sitting up because there's no point. The gravity is not going to help. So all these eye drops, they use them, they apply them on the surface while lying down and then leaving it on the surface. But I agree, retention time is a problem, yes.
Okay. Does oral doxycycline change the inflammatory profile on the surface? And from your experience, which type of steroid works best with Sjogren's and Gvhd?
Oral doxycycline is very important, I think. We give it 50 milligrams once a day to all our Gvhd patients and Sjogren's patients. The only reason I would stop oral doxycycline is if their liver enzymes are not normal, or if they have liver Gvhd or some issue with that, then you stop it, or if they're allergic or if they cannot tolerate doxycycline. But doxycycline, I think, has a very, very good anti-inflammatory profile, not just for the meibomian glands and eyelid disease, but also on the surface of the eye. It's incredibly important to give doxycycline 50 milligrams once a day. We don't need more than that. Which type of steroid works best with Sjogren's and Gvhd? I think in general, but more so for steroids, everything that is non-preserved is a good idea. For steroids, we compound non-preserved methylprednisone 1% eye drops in our UIC pharmacy because it is non-preserved. So that makes sense. The other steroids commercially available, you want to go with one which has the least amount of benzalkonium, okay? For example, Lotemax, the general solution, Lotemax suspension has the full amount, 0.05%. So that, just like Predforte, so that doesn't work very well. But the Lotemax gel, on the other hand, has 70% less. And Lotemax, what is that, SM, the new one, the Lotemax SM has also 70% less. So our go-to steroid is the one which has the least amount of benzalkonium inside. And that translates to Lotemax SM and Lotemax gel as our choice number 1 if we are going commercial steroid. And choice number 2 is FML because it has lesser than Predforte, but more than Lotemax gel and Lotemax SM. But the ideal is preservative-free methylprednisone. We remember that we don't need benzalkonium because we don't want the steroid to go inside the eye like uveitis people. We want the steroid to stay on the surface of the eye. So we don't, benzalkonium is not helping us at all. So we don't want to see that. Does it make sense?
Yes, totally. Okay. Perfect. Well, I think it was a very, very good talk and good discussion over here. Dr. Valdez, do you want to?
Yes, I just want to really thank you, Dr. Sandeep Jain. We really enjoyed this seminar. It was a lot of thoughts on dry eye and things that we can pursue in research. Thank you very much for your generosity of your time and sharing this knowledge with us. It's really our pleasure to have you here. And I think this will strengthen the bonds between UIC and Monterey Tech. It's part of our collaborative work.
Yes, thank you very much for Dr. Valdez and Denise and everybody else who was on the call. I wish you were not blocking your videos so that I could see you and you can see us, but all the other people are blocking their videos, which is...
We can ask them to, you will see, podrían verlas para que vean. You will see all the things.
Robert, ¿pudiéramos accesar que todos se vean, por favor? Digo, los que quieran, ¿verdad? Y se puede.
Los que están peinados. Those who are already...
it's nice to see everybody's faces and, you know, who we are.
Yes.
But I think you bring a very important point. What we are doing, what we just heard right now, and what we are doing and intend to do is to bring about a change. Because we know that there is a lot of people who are suffering, right? And we also know that we don't have too many therapeutic options here. So I think there is a great opportunity for us to collaborate and to see that what else we can do for these patients, which can benefit them. And I would encourage you to go and read about pooled human immune globulins in other conditions and what their actions are and what they do. And you will realize that other than steroids, nothing comes close to it. That is a wonderful, wonderful thing that does, of course, what kind of dosage, how to give it. There are many questions to bring it to a patient, but they are safe and they have a broad action. My only issue with when we thought about is that why weren't people using it for all this time? And I have no idea why for all these years, nobody was using it to treat autoimmune conditions when this should have been a logical, it's like obvious that you would use it, that this is an obvious answer. So I feel that we have great opportunity to work on this together if you want.
Yeah, thank you very much, Dr. Jain. It was a pleasure. And I think all of you have done a wonderful work. Is very excited and to see how things are working there. And thank you very much to share your time with us today.
Okay, thank you. Very well. Thank you very much. Wonderful, my pleasure. And so nice to see everyone actually got their videos out.
Licenciada Margarita,
okay. Gracias. Thank you so much. Yes, thank you so much, Dr. Sandeep and Doctora Denise Loya. Thank you so much for your coordination, Dr. Jorge Valdez. Y muchísimas gracias a todos los participantes. Enhorabuena por todos estos aprendizajes y educación continua que estamos teniendo hoy en día. El día de mañana también vamos a tener unos seminarios, si nos gustan acompañar. Mireya, ¿nos puedes apoyar, por favor, para presentarlos? Es el curso de desafíos actuales de cirugía fotorrefractiva, para que por favor nos acompañen. Es a las 10 de la mañana, es mañana viernes y sábado. Y la próxima semana, estos seminarios internacionales, vamos a cambiar solo por esta ocasión. El jueves va a ser a las 2 de la tarde. Ahí vamos a tener otro seminario internacional muy interesante para que por favor estén al pendiente y participen con nosotros. Que tengan muy buen día. Muchísimas gracias por estar con nosotros.